Welcome to the lecture that was at the BDA and the Dentistry Show in 2018. And it's the introduction to the Bioclear method for what we'd like to think of as monolithic, superior, anterior composites. This is actually what we can gain directly with composite. And it shows you it's an advanced case, but it shows you what we can do nowadays with the method, the Bioclear method, and direct composite. So it really opens up lots of avenues for us to be able to use. My name is Claire Burgess. I am the UK certified Bioclear instructor, and I should be going through just a brief hour of actually what the Bioclear method is and how we can use it for anterior solutions. So the Bioclear method is a term that a lot of dentists haven't yet actually come across. And so what is it that's driving our beginningness and our awareness of this method and people inquiring about it? First of all is actually patient awareness, and it's a very big driving force. A lot of patients today are really interested in going on the internet, looking at alternative solutions to address their concerns, whether they be cosmetic or whether they be functional. And another aspect that's actually really driving this conversion and this interest in the Bioclear method is science itself. So let's first of all have a look at some of the patient inquiries and actually what's driving their awareness. So here are a couple of examples of emails that we've had sent in to us at the practice. And we normally get emails probably about once a week that come in, normally related to black triangles. And these patients are people who are unaware of us as a practice or my role specifically as an instructor, but they have concerns, and most importantly about black triangles. So as we can see here, my black triangles on my bottom teeth really upset me. And upsetting is quite a strong word. We don't consider it to be necessarily, but black triangles really do affect people. And this is the photograph that we have sent in, and we have many photographs in many forms, and they're really passionate, lots of mobile phone photographs of the teeth. Also people who have had, let's say, gum disease, or especially at the moment, shorter term orthodontics, such as Invisalign. They can see a number of black triangles that they're becoming aware of, and they're told that the only option that they have is veneers. Lots of people don't want veneers because they actually understand the preparation and the amount of tooth removal that's required to be able to do these veneers. So again, they've started Googling around, they've found the Bioclear method, and they're inquiring about other options for it. The other main category is, and actually what's driving the Bioclear method, is science itself. And this is actually what really brought me into actually exploring Bioclear, some of the matrices, and most importantly, the method. So if we actually think about composite versus porcelain, which for a lot of cosmetic reasons at the front, they're the questions that we're going to be asking ourselves. Are we going to use composite in a direct method, or are we going to do indirect forms with porcelain? And as we go through with composite, it is much less preparation. In some instances using the Bioclear method, such as with diastema closures, black triangles, peg laterals, literally all the preparation is just cleaning the tooth. There's no actual burr action taken to the tooth. So it is much less preparatory and also much less destructive in nature. Obviously, the less preparation that the teeth require, that means there's much less risk of non-vitality to the tooth as well. So that's going to be much better for it. People who come in for the Bioclear method when they're having restorative treatments have it all in one session. So again, there's no need for temporaries, there's no need for impressions, for retraction cord, which obviously can risk the biological width violation. People don't have temporaries that sometimes can de-cement, etc. So it's a single treatment option, which actually suits a lot of people today, especially in today's very busy world, where people want to come in, have a treatment completed, and then go away afterwards. Also, you'll tend to find, because we're not involving porcelain costs, such as laboratory fees, etc., then the cost for direct composite is less as well. So normally you would say approximately about 2/3 of the cost of what you would charge indirectly for something like a veneer or a crown. And with composite restorations, direct restorations, the risk really lies actually with the restoration and not with the tooth. So if something is going to fail, it's more than likely going to be the composite that's either going to chip or break, rather than actually fracture of the tooth, which can happen when we look at indirect restorations. If we compare to the other option that we've got for what I call traditional layered composites that we have, they're actually technically very difficult to do. It's something that we're taught about when we're at university, and it's almost taken as a given that all of us can produce really good layered composites that look just as good in 5-10 years' time as they did when we placed them. And a lot of the time they'll look beautiful when they're placed. But then what you will find over time is that either areas will chip, things will stain, you'll get those lines around some of the restorations, as you can see on the photographs. Trying to get a good emergence profile between the teeth is very hard to do, especially when we're hand building that emergence there. So quite often you'll get overhangs, you'll get ledges, etc., which obviously affect the gum health as well. Another thing that you'll tend to find with layered composites when we're trying to build in the dentine and the enamel shades is that we ultimately end up with a tooth that's actually got more greyness to it, it's got more translucency to it. And when we ask patients about translucency, they really don't like it. They see it as being this greyness, and they also see that almost like as if it's a weak tooth because of the grey colour that you have. So if we compare here, this is somebody who had some traditional composites done to close some black triangles. And I think every practitioner will say that's a very hard process to do. And so you can understand why we sort of avoided treating them because we haven't actually got a predictable and easier method to be able to do this. So if you have a look in the top picture, you'll be able to see where the composites have been built. They have closed the triangle, but can you see how you've got the overhangs and the ledges that's there? This patient actually underwent traditional composites on the top, that we can see, and then she uncovered the Bioclear method, and she had Bioclear method black triangle closures for her bottom teeth. After that, she found that they were much easier to clean. So she asked if actually she could have the old composites removed on the top and have them replaced with Bioclear method composites. And if we have a look at the bottom photograph, you can see the result of being able to use the Bioclear method. If we have a look at the emergence profile, see how nice and smooth they are. They're much easier to clean. There's no overhangs, there's no ledges, and they're really nice and smooth. And this is a predictable treatment that we can give to our patients. So if we have a look at it, the Bioclear method versus traditional composites. With the Bioclear method, because we're heating our composite and injecting it, it's in a solid block. It's what we call monolithic. So that therefore makes it much stronger than if we have small individual layers of composite. So it's got much better strength to it. And as a result as well, it's also got a much higher stain resistance value to it. And it's almost similar to porcelain. So you should be able to place something like a porcelain crown next to a Bioclear method composite, and you should not be able to tell the difference with the polish of either. So what actually is this Bioclear method, which is what we instruct on? The Bioclear method has 4 cornerstones to it, and this is applicable to every composite that you do, whether it be anterior, posterior, whether it be just a simple distal on a central incisor, or whether it be a full 360 veneer. The first cornerstone is actually removing the biofilm and looking at our cavity designs and extending them, so therefore we have this infinity edge margin, which we spend a lot of time going through at the learning centres. The second part is actually having an anatomical matrix, and this is actually what brought me into discovering Bioclear. I'd never seen an anatomical anterior matrix before, and it really transforms how we can do our composites predictably at the front. So anatomical matrices, and also knowing how to handle them, select them. Third of all is actually heating our composite, so we end up, as I said, with this monolithic, nice, solid, strong form of composite. And then finally, the fourth cornerstone is the rockstar polish, and this is what really allows us to challenge porcelain in the front area of the mouth. So let's have a look at those 4 cornerstones in more detail. First of all is this idea of actually removing the biofilm, all right? Biofilm is everywhere in the mouth, and etch does not remove the biofilm. So therefore we have to mechanically remove this from the teeth. And if we disclose the teeth, you will see it is everywhere. So how do we actually remove it? We remove it with a combination of blasting some powder and water against a tooth. The powder we select is aluminium trihydroxide. The reason for this is the fact that it's not too abrasive, unlike aluminium oxide, which is much harder, But the aluminium trihydroxide can be used on the tooth. It very lightly abrades the enamel, and we can also use it inside the tooth, let's say if we're in the posterior area of the mouth. And if we actually think about indirect dentistry here, they're starting to come out with articles about the fact that you get a dramatic improvement in bond strength for our indirect restorations if we actually remove the biofilm when we're cementing crowns and onlays, etc. So if we're thinking about removing the biofilm for indirect work, then maybe we should think about removing the biofilm for direct work as well, because our bond strengths will be so much better again. So this is actually a tooth that was placed in filling that was placed in 2009, and then in 2013, so only 4 years later, if we have a look, you can really see where the stained margins are. Now, that composite originally didn't have that sharp margin to it, but if you can imagine, if you've got your composite and it's going from thickness up to thinness here, if I have biofilm here where the composite is very thin, it's going to start to chip and break away. Then I am left with a really rough ledge, and that will stain. So this is why we want to remove our biofilm, so that the tooth is completely clean, so that composite can actually go to infinity. To do this, we dry the teeth, we disclose the teeth, okay, so you can actually see all of the biofilm that's there. We blast the whole tooth, as I said, with aluminium trihydroxide and water. And then you're going to actually wash the teeth, dry them, and repeat the process. You'll be really surprised as to how much biofilm is actually left there after the first go. You'd think you'd remove it all, but unfortunately, quite often there's a lot of actually left. So we remove the biofilm twice. This is actually a slide showing the biofilm that's left after a hygienist visit. So you can actually see the mark from the sickle scaler that's there. So this shows even after seeing the hygienist, look at where the biofilm is. It's all between the teeth and the nooks and the crannies, areas that are very hard to get to and very hard to clean. So if you were looking at those triangles and thinking of doing some restorations to be able to close them, you can see that they're likely to fail because they're not going to get a good bond strength to the actual tooth. So we must get into all of the nooks and crannies and remove the biofilm, and blasting it is a much more efficient way to do it. After 5 minutes, look at the difference. You can see the root surfaces are really lovely and smooth there. So it only takes 5 to 10 minutes, depends on how many teeth that you're restoring, but it's really valuable point to be able to do. Also, if you think about going back to black triangles, some people who've had, let's say, gum disease and they've got some recession, they might have large triangles, but their root surface is very irregular. How are you going to start to get in those real nooks and crannies and be able to clear that all away? As we can see, after the blast has been in there, you can see that's lovely and clean and smooth. So now I can attach the composite on. Second part, which as I said is what brought me into the world of Bioclear, is anatomical matrices. At the moment we just have flat matrices in the front zone, but these are actually anatomical mylar matrices which give us a really smooth, rounded emergence profile. So when we use the matrices, when it comes to actually finishing, we don't need to do any finishing between the teeth, which as dentists, this is a really hard area for us to do without creating things like ledges and overhangs, etc. The areas that we need to finish once we're using the Bioclear method is just facially and palatally, which is areas that we can easily access. This is a clinical example basically of what we normally have in surgery. You've got your flat mylar strip again. Either you'll tend to find that you haven't got it as close to the tooth at the neck, so therefore maybe you get the overhang or ledge, or in this instance, we've been able to use a wedge to get a full seal at the bottom, but then unfortunately afterwards you end up with that black triangle, which as I say, patients really don't like. So if we have an anatomical matrice, that actually makes things change. So we're going to move from something that's very straight and very flat. Nobody's teeth are straight. So we're going to remove it to something that gives us the anatomy back. As you can see from the x-ray there at the top, it's like a tulip shape. You can see the emergence really nicely. Top photograph there is the x-ray, and you can see where somebody's had black triangle closure composites. You can almost see where the burr's gone in just to try and finish it, and unfortunately it's just nicked it. So you can see where the sharp overhang is there. As you can see on the bottom one, that's the shape of the Bioclear. So you get that really nice tulip sort of shape, very smooth, no overhangs there, easier to maintain. When we're looking at matrices, there is a selection. One matrix does not fit everything. So we go through this at the Learning Centre, but if we think about such as the mesial side of a central incisor, it's actually quite vertical, it's quite straight. If we think about a distal matrix, it's got loads of flare to that side of the tooth. So we want a matrix that's going to mimic the shape of the tooth that we're actually dealing with. So there's lots of matrices for many different cases. The idea with the matrix is the fact that it sits about 2 millimeters subgingivally. And then what happens is you have your matrix and the gum presses against the matrix and forms the seal at the bottom. So as you can see on the model, the matrix is slid underneath the gum there. A small section of flowable composite is going to be injected right into the very bottom. And then if we take the tooth out, you can see where the composite is completely flush with the tooth at the base there. And this is what we're able to mimic clinically. Matrices, it's quite straightforward, but these are some of the examples as to how the matrices help us. This really deep distal cavity there, I think a lot of people would be almost dreading it, because you know that once you put a flat mylar in there, it's going to cut the gum, it's going to start to bleed. How are you going to be able to get the emergence on that tooth? Because it's actually quite a big space you're trying to close. So this is just classically a distally shaped matrix. It's got the curve to it, it's going to slide underneath the gum, and then you can restore the restoration. Thinking about diastema closures mesially, okay? With that, you want something with quite a straight edge to it, so you get a really nice straight center line. So with these ones though, because we've got a space to close, we're going to use what's called diastema closure matrices, i.e. they've got hips on, so they can build the shape of the tooth out. So sometimes you'll use these as well with things like black triangles. So in this instance, you'd blast the tooth, and then you'd place your matrices in and restore, and that's all the preparation that you'd need. Black triangles, as I said, is quite a shape, it's quite a triangle shape that's there. So I probably want something again which has got that hip to be able to expand the emergence profile, the shape of the tooth. So again, it will be something like a diastema closure matrix, but maybe with a bit of a trim to make it a little bit smaller. So we customize them to make sure that they fit uniquely to that tooth. Peg laterals, again, you've got quite a big space both sides that you're trying to build out that tooth and restore it in. So again, I probably want to have something which has got a hip to it, more of the emergence, so I'd go with diastema closure matrices both sides. So when we come to the Learning Centre, we go through the courses, we go through how to select the matrices. It's quite a straightforward process, and we get very used to doing it, and then you get the better results. Number 3 in the cornerstones was actually heating our composite. So we end up with this monolithic composite, this really good, strong composite. So if there's no gaps and no voids, it's going to be much stronger. It's also going to have a much better shine to it, and therefore a better stain resistance to it. And if we think about layering composite, we have a small little layer, almost like building a wall. We have a little section on a section on a section. So we have quite a few seams to each of the cold layers of composite. So you can understand when they had to look at the voids, how at the bottom there it says there's 33% of voids with traditional composites, and you could imagine that. But actually I was surprised with the sonic fill. But if we look at actually the Bioclear method of injection moulding, our flowable and our heated composite, we ended up with 1 to 2% of voids. So that's going to be so much stronger than something, let's say, with 33% of voids. And the nice thing is that that figure actually came from delegates who are attending a learning centre. They all injection moulded into a tooth, and then sections of the tooth were studied for voids. And it actually came out, as I say, that there's 1 to 2% of voids. These are people who aren't used to injection moulding of composites. They haven't come across heated composite before. So therefore it shows that it's actually quite a predictable and easy method to be able to place our composites. If we think in the porcelain world, a lot of the world's going towards monolithic porcelain, because unfortunately where failures normally occur is between the base porcelain and the overlying porcelain. So again, if the indirect world is coming towards the idea of monolithic strength, then maybe at the same time we should be thinking about that with our composites as well. This is actually a case of somebody who's now 13 years on, and it's a case where someone's got quite a bit of wear to them. They've had their restorations placed with composite using the Bioclear method, and this is 13 years on. And you can see there's no chipping, there's no staining, and they're nice and strong. And composite's thought of as being quite a weak material, especially incisally, and lots of things tending to chip. But actually, when we have a look at it, it's used in the correct method and obeying the rules of composite, it's actually very strong. Compressive strength-wise, if we think about milled composite, there we go, and we actually place a block of monolithic composite, heated composite next to it, it has the same strength. So we can really look at this actually as a much stronger material and a very good durable material as well. If we're going to heat our composite and inject it in, obviously we need a heater to go with it. This is the heatsink heater, the Bioclear heater. And the reason why I like to use this is it heats the composite up to 70 degrees. So it really takes it into a very good activity level. With composites, it's above 58 degrees. So it takes it beyond that, which means the monomer is more active. So therefore, you're going to get a better polymerization and a better depth of cure. On a very practical aspect though, it has what's called this oven, which as you can see is where you've got the compules right in the center, and the oven has a little lid. And what's important is the fact that sometimes you might use, let's say, 3 compules of composite just to restore one tooth. And I want the whole of that compule to be at 70 degrees. I want it all to be heated, not just the little end that fits in the heater. I want the whole compule to be nice and warm, because composite's got a very poor thermal conductivity. So if we take it out of the heater, as soon as it comes out, the temperature's just starting to drop off. So I want the whole thing to be nice and warm, so I can store up to 6 or 7 compules of composite in that little oven. I can also heat up the 2 composite guns in the sides, so that's all nice and warm, and the flowable as well. So you can heat multiple compules, which means then everything is warm as you're using it. Obviously, the warmer that it is, it's going to flow better. So they say up to 10 times better. So it's going to get right into the nooks and crannies of all your composite restorations that are there. So therefore, your seals are going to be better and your marginal integrity is better. If that's the case, then obviously your secondary caries level is going to be lower as well. Research has been done that shows by heating the composite, it doesn't damage the pulp at all. And also studies have been done with the Filtech material, 3M's Filtech material, that we can heat the composite, cool it down, heat it up again up to 25 times, and there's no change either in their chemistry or in the colour stability as well. So it's a very nice way of actually heating our composite and injecting it in to get this monolithic form of composite. Finally, we have the Rockstar polish, all right? And a lot of the polish that we're able to get on it is actually down to some of our finishing and our shaping techniques, the use of soft discs and the use of brownies, etc. So once we've finished all our sculpting, we'll come on to our polish. And there's 2 main sections to it. One is called the Magic Mix, which is like a gel form, and contains large and small particles of aluminium oxide. And we run this over the tooth with a Profi cup all over the tooth there. And then we wash it away. And what you'll find is the surface of the tooth, once it's dry, almost looks like etched enamel. It's really smooth, okay? And what the particles do is they leave very, very fine little grooves just in the composite that then reflect the light, so it looks really shiny. With regards to the Jazz Polisher, it's a silicon impregnated cup, silicon diamond impregnated cup, and we use that with water, so we don't bake the composite, and we use it with quite a lot of pressure. And what that does is really get the shine on the tooth. And to test the shine, dry the teeth, because if they have saliva on, they will always look shiny. But actually, if we dry the tooth, it should have exactly the same shine as it does when it has saliva on it. This is the reason partly why I use the 3M Filtech is actually the polish retention on it. It's a pure nano material. So as the composite wears, you're still starting to keep all of the sparkle and the luster in the composites. So what can we actually do with the Bioclear method when it looks at anterior restorations? So as I was saying, this is that case that we saw using the matrix, where you've got that really deep, horrible cavity that you know would be very difficult to be able to do with a flat mylar if you were in surgery. And I love this case because actually this was a delegate's first case on Monday morning after being on a course at the Learning Centre. And I think that's a great achievement to be able to do for your first restoration that's there. It's got a lovely emergence profile, it's really smooth, and it's got a great blend with the tooth as well. This is a case of somebody who had orthodontics and then had a traditional layered composite to replace the old her old one, but wasn't very happy because you could still see the margin that was there afterwards. So she'd come across the Bioclear method, so we decided to go ahead and replace the traditional composite with a Bioclear method composite. As you can see, the shine is really nice on the tooth that's there, and this is it 2 years on. And actually she got hit in the face with a dumbbell in a gym class, and I really expected the phone call to come through saying that the composite had broken, but it's still intact. So as I say, 2 years on. Black triangle disease is actually the third most common complaint of patients, or the public, should I say, out there, behind caries and visible crown margins. So it's something that patients really do find upsetting. People will even say, I hate my teeth because of this. So they're very passionate about it. And actually about 30% of people have black triangles. So there's a lot out there that people actually would like to be correcting. But obviously, as I say, unless we have the right techniques, we sort of tend to shy away from it. Reasons behind it obviously is going to be bone loss and recession from things like gum disease, but also much more now is the movement of teeth and short-term orthodontics that's there. So this is somebody who had completed a case after Invisalign. We can see it's actually quite a prominent central black triangle that's there. But if you have a look between the centrals and the laterals, you've also got quite triangles there as well. So he came up and we restored the triangles in the 1 day there, and that's the result afterwards. So you can see how the triangles have been closed, and then also what you'll find is that papillae regenerate in that area as well. So you start to get that nice triangular papillae reforming. What we tend to do in a case like that, if we look at the bottom photographs, is you'll restore it actually tooth by tooth, not triangle by triangle. So you can see my matrices in place at the bottom there. I've injection molded one of the teeth, sculpted it, then gone on with my other central, and then eventually on with my laterals. So we go through the smile design process with that as well, and the order that you would do it in. And that's afterwards, so he was really pleased. This is a case of a peg lateral, and you can see there how you've got the matrices in place. You've got the flowable composite in there, just building out those hips. So you've got that really nice emergence profile. And then you've got the final restored tooth there, and you can see it's a really nice shape and blend. You'd never know that that's a little peg underneath. This was a case of a lady who didn't want orthodontics. She'd received several opinions beforehand on it, and actually all that she wanted was literally diastema closure on the front 2 teeth. And we go through as part of the course smile design, etc. Because with this lady, if we'd actually gone and carried out what she wanted by just addressing the 2 front teeth, you'd have found those 2 centrals would have been really wide, so it actually wouldn't have been a very pretty smile. So with her, we talked through just addressing the centrals, but actually bringing the lateral incisors into play as well. And when we were doing that, therefore there was much more balance in the smile. And you'll see in the bottom photograph, she's got almost like a golden proportion caliper against her bottom teeth. And that's called a smile gauge, and that has golden proportions from 8, 8.5, 9 millimeters, which you can hold up against the teeth. So therefore, when you're trying to gauge that you've got symmetry between the left and the right, it really helps to guide you through your path, or even guide you when you're prescribing to a laboratory for indirect work as well. So for her, she ended up with 9 millimeter central incisors, and then the laterals were the same size as well. The Bioclear method is a really good way also of treating fractured teeth. So people who came in, this gentleman came in requesting a crown because he thought he'd fractured his tooth so much that there was no way that anything else could be done. He'd have to have a crown. Where actually he underwent the Bioclear method process using the 360 veneer matrices on the front tooth, and then actually afterwards started to think that his laterals were quite small, which they are. So he had over mouldings on those to therefore correct the 4 front teeth. So he ended up with much more of an ideal smile. And this is a really good, valid way of treating people who have fractured teeth, especially when they're younger patients. And we want to be looking at definitely direct over indirect if we can, but something that's going to be strong and it's not going to be chipping all the time. So this really has its place. This case is always close to my heart. It's probably one of the toughest cases that I have done, and it's actually my godmother. And she has really bad Sjogren's syndrome. She's a retired orthodontist, so her oral hygiene, thankfully, was amazing. But she started to have composite placed around the teeth just to try and prevent caries, etc. They were chipping, they were staining. And she wanted to know if there were alternatives that we could do. And actually, once you stripped away the old composite that was there, the teeth were going in all directions as well. So we had diastemas, we had teeth in different angulations. So for me, the smile gauge at the bottom of the slide there came into its own completely, because it guided me through the width of each tooth as I was restoring it. So we used the Bioclear matrices. We restored the 2 centrals, made sure that we had symmetry on those, then went and restored the 2 laterals, the canines, and then we also restored the upper left 4, which was a rotated premolar. And when we have a look at the end result that was there, you can see all the triangles have been shut, the teeth are more regular, there's much more symmetry left to right, and we've also managed to change that premolar, which she really didn't like, that's there. Again, she's finding it much easier to clean her teeth, food isn't trapping between the teeth, and the result was really nice. This is an extreme example that shows you actually what hopefully Bioclear can do for you. This is somebody who's attended, obviously after a long period of neglect of his teeth, wants to regain his health. We don't know how much commitment he would have to actually his maintenance in the long-term future. Is it going to be someone who we just have a quick fix for and then doesn't come back afterwards? Financially, some of the issues there, implants, etc., weren't possible for him as well. So when we have a look at the x-rays, I'm sure there's several people who would sit there and say, we're going to have to definitely take out, for instance, the upper right 1, the upper left 2, etc. But actually, when we have a look at the radiographs, you can see that amazingly, at this stage, there's still no forms of pathology at the end there. So if we can stabilize this patient in a way that addresses his cosmetic issues, and stabilizes him so we can see what his maintenance is like, and do it in the least destructive way possible, then that would be advantageous. Also because it's going to be a much less costly affair than looking at extractions and indirect restorations, etc. So for him, the process was the modified Hall technique. We spend a lot of time going through that in the posteriors there. So we're making sure that obviously we're selectively leaving some of the caries centrally, but that we've got a really nice clean border, ADJ, around the teeth. The centrals, first of all, is restored, and that was nicely polished. Then the matrices, as you can see with the blue etching, that's the lateral on the upper right too. That's been over molded, so you'll see the big belly button of composite coming out on the lateral there. That was then sculpted back, and then the veneer matrices were used finally on the canine there to restore it. And this was him after you'd had the restoration of basically the top 6 teeth there that was there. So we've sort of maintained every bit of tooth that we can. We've almost hugged or wrapped the teeth with composite that's there. Obviously there's more work to be done, all right? But this was his smile afterwards. So it's a massive change for him, and it's a really good stabilizing way. And if some of those centrals do lose their vitality, then that's absolutely fine. We can basically, if we wish to keep them, you can restore them through the back with endodontic therapy. But again, you're going through composite, so you can reseal the composite afterwards as well. So a really good method, a strong way of securing his teeth as well. And as I say, seeing what could be possible over time. So, as you can imagine, Bioclear doesn't fix everything, okay? So there are some limitations to it. So we're quite used to, with indirect work, especially cosmetically, in getting diagnostic wax-ups, that we also use the putty stents that come from these as well. But actually with the Bioclear method, diagnostic wax-ups aren't actually really possible, not to be used in the mouth, okay? Because we're going to be using all our matrices and we're building it directly. However, I will still do some diagnostic wax-ups, and that's purposed mainly for patient education and for medical legal reasons. So for instance, that lady who had a really big diastema between her 2 front teeth, I did wax-ups both with just the centrals and also with the centrals and the laterals, so she could have a look at the 2 different types of restorations and the sizes of the teeth. Diagnostic wax-ups are possible, but I would also ask the laboratory to do a Bioclear shaped tooth, because as you'll see from the photographs there, they have a very oval sort of shape in the gingival area, and they're almost more ovoid, more rectangular in shape, the actual teeth. So therefore, if you have somebody who really likes quite a triangular shaped tooth, you're not going to be able to establish this with the Bioclear method. So one, prescribe it to the laboratory that you want a Bioclear shaped tooth for your wax up, and actually show examples to your patient of the shapes of the teeth. There's no provisional restoration, so we're not able to do things like a trial smile. So routinely in the past, you take almost like a pull down of your wax up and try it all in. With the Bioclear method, you're using your matrices and you're injecting it, and that's definitive treatment that's there. So there's no provisionals, there's no trial smile that's there. Maintenance, normally you'll tend to find that you're polishing the Bioclear restorations normally about every 12 to 18 months. A lot will depend really actually on their diet, how abrasive they are, especially with things like toothpaste, etc. So sometimes you'll find it can be 2 or 3 years before they need to be polished. And when they do, it's a case of the jazz polishing cup again with lots of water and just polishing over the tooth just to bring that surface shine back up. Isolation is important with any form of composite that we do, but yes, excellent isolation is ideal. We must obey the rules of composite as well, similar to how we would do for porcelain. So we really do want 2 millimeters incisally or occlusally. So if we're looking at changing the lengths of teeth, if we're looking at overlaying posterior teeth, you want that 2 millimeter thickness of composite incisally, all right? Because if not, even though it's monolithic, it's not thick enough, so therefore it will chip, okay? Hands-on with regards and training to it, it is a new technique. It's like everything that we learn. First of all, when we use sectional matrices posteriorly, there's a learning curve attached to it. We spend a lot of time at the learning centres on the courses really going through lots of information that makes life much easier when you're actually using the method in surgery, and also lots of practical time that we spend with you. So it's more practical in some ways than theory. The matrices were actually designed by David Clark in 2007. So obviously we learnt long-term studies on the method and the matrices. So we're just past the 10-year way. So there are articles coming out, but it's like any new either method or material, it takes time for this to come through. So hopefully there will be more articles coming through over time. So that's us looking generally at our anterior solutions. I'm also going to look at some of the advanced anteriors, which really can show what we can do with regards to composite nowadays in the front. And the two areas that I'm going to look at is actually occlusal rehabilitation, so opening up the bites for people, and also after orthodontics, when people have had all the teeth beautifully straightened, but then you're into the realms of different shaped teeth because of different wear in the past, etc., and how we can restore those. So if we think about wear on teeth and looking at composite in the past when it used to be used as a material, it's got the same or similar wear ratio to enamel, so it's a really friendly material. But what used to happen was the composite used to chip or it used to stain. So therefore you're constantly almost having to do repairs to it, all right? But if we use the Bioclear method, so we've removed biofilm for a start, we're obeying the laws of the thickness of composite and we're using monolithic composite, then it means that this is much less likely, so therefore we can really look at using it with occlusal rehabilitation. The slides, the case on this slide is somebody who, as you can see, has got a lot of wear. So my colleague Dominic Hassel was restoring the upper arch, and then I restored the lower arch using the Bioclear method. And if we have a look at those teeth, they are so small, there's hardly anything left to them. So I really don't want to be doing any preparation to these teeth. So I'm just literally going to round off any sharp line angles, and then I'm literally going to wrap the teeth in composite. So you can see there afterwards, once we've increased the OVD a couple of millimeters and wrapped those teeth with composite, they are much stronger, and we're now 6 months, a year on with those, and they're really nice and solid with no chips and breakages. So this is actually somebody who attended because they're unhappy because they felt they weren't showing enough teeth when they were smiling and it looked a bit older, all right? Which if we have a look at the retracted view, you can see where the wear is that's there for him. So with him, we are literally opening up the OVD. He's a suitable patient with regards to, or candidate, for opening up using a dial-like appliance. So with this gentleman, we used the Bioclear method to make a dial appliance on the front 6 teeth. So we've opened up the bite, we've reinstated the good guidance, canine guidance laterally, and then restored the posteriors in. And this, as I said, is this smile gauge. So this really shows me the widths of the teeth as I'm building them. So I've got much more direction when I'm shaping teeth and polishing teeth. So initially you can see on the gauge he's going to be an 8mm wide central incisor. And the bottom picture there has basically after I've restored the front 6 teeth that's there. So I'm nicely in symmetry, left and right that's there, and we've also opened up his OVD using the palatal build-ups with the composites. So we restored his upper arch to start with, and then filled in the composites posteriorly, left him be for 3 months, and then we repeated the process again on the lower arch, again using the Bioclear method on the front 6 teeth, opening up his bite a little bit, restoring them with monolithic composite, and then filling in the spaces posteriorly again with composite that's there. And then that was him after we had the smile. So again, you can see how the teeth, they've been almost rejuvenated by bringing back down the length. He does wear a protective shield at night because we know he has parafunction. That's the reason why he was in a bit of trouble to start with. So we want to protect what we've placed. We know that if we needed to make any adjustments on the amount that we've opened, it's in composite, so we can nicely ease that back down if we needed to. We didn't in his instance, but that little safety feature is there as well with composite. And it's doing really well because it's now 5 years on for this gentleman. Looking at orthodontics and post-orthodontics, this is a lady who has gone through 6 month smiles. She wanted to change the teeth after. She's always very conscious of her teeth. And as you can see, the veneer on the upper right too is quite stained, so definitely wanted to replace that. But also if we have a look at the unevenness of the incisal edges and also the unevenness of actually the width of the teeth themselves. And actually the central incisors were 9.5mm wide because it's quite a broad jaw that she had. So when you looked at that, one tooth was wider than the other. So if you have a look, the upper right one is definitely wider than the upper left. So what we decided to do was to actually Bioclear veneer the anteriors, including the premolar on the upper right, because it almost was quite retroclined inwards. So we want to build out the buccal profile of it. And we were going to do all of the teeth, including the old veneer, with Bioclear method veneers instead. So we went through the process. We measured out the 2 central incisors, got those 2 to match each other first. Then we went on with the laterals, the canines, and then finally the upper right 4. And that was basically after we'd done the veneers. You can see the polish that you're getting on them, really nice and shiny that's there. The nice thing, apart from the preparation of removing the old veneer on the upper right too, and also by removing, by taking away some of the enamel on the distal of the upper right one because it was too wide, that was pretty much all the preparation that we had. There was no preparation around the gingival area at all, okay? So the composite literally just runs to infinity onto the tooth there at the base. So much less destructive option that's there. And as you can see with her smile before and after. This is my final case, which is somebody who actually had fixed orthodontics. So as you can see, the gum levels, the symmetry and the zeniths is absolutely perfect, all right? But the issue was obviously the incisal lengths where the old wear had happened. You can see they're really irregular. So again, I've got my smile gauge out. I'm measuring the sort of widths of the tooth. With her, she's got virgin teeth. There's not even a restoration there. So I don't want to be cutting down the teeth, even for veneer preparations. So again, we're going to go with direct Bioclear method veneers for her. We've got our scales. We know exactly the widths of the teeth that we're going to be restoring to. So I've removed the biofilm initially on all the teeth there. Because we're increasing the length, I must need 2mm of composite. So I have done some incisal amputation on the upper left one there. I've then used my matrices, I've overmolded it, got the shape that I like, and then I've repeated the process on the other central incisor and overmolded it, which is the bottom photograph there at the end. And then we repeat the process looking at your laterals and looking at the canines. And then that's it afterwards. You can see you've got that lovely symmetry between the left and the right. You've got a really nice shine on it, and it looks really natural. And a lot of the time you'll find with the Bioclear veneers that they actually do look really natural, because as the composite is running down the neck of the tooth to the gingival, it's getting thinner and thinner and thinner. So the natural hue of the tooth comes through at the end. So a lot of the time, as I say, people, they just look really natural and they feel very smooth and very strong, is the comments that we have back. So hopefully going through that shows you some of the aspects of what we can do, from just a simple, horrible distal, deep distal cavity, all the way up to literally smile design with people. So composite, where are we going with it? I think definitely it's superseded by the idea of using monolithic composite, so we don't have as many voids, so it's stronger, so it's not going to chip, it's not going to stain as much. When you're looking at things like black triangles, diastema closures and peg laterals, it's a really strong method for restoring those because it's preparation free. We've got to blast the teeth whether you use traditional composite or Bioclear, but this is an ideal way of getting a really nice restoration in those instances there without having to go in direct, and it's predictable and it lasts much longer than that as well. And also it's lower cost. So for people that do have some cosmetic concerns but can't afford things like the indirect fees, etc., then it opens up avenues for them as well. So it's definitely got its position in dentistry. So obviously I'm the UK instructor for the Bioclear method. The Bioclear, there are actually certified learning centres. There's 3 of them in the world. First of all, there's David Clark and Dr. Kim actually in Seattle, in Tacoma, where Dr. Clark lives and comes from. There's Solihull in the UK, which is where we're based, and there's also a learning centre now in Sweden, but that just does posteriors. So there's a curriculum level within the Bioclear courses that goes from standard, almost foundational levels up to advanced levels. And for us in the learning centre, we do both the foundational and also the advanced levels. So the learning centres, they're in Tacoma, they're in Solihull, and they're in Sweden. And this is a picture of our learning centre in the United Kingdom. That's actually the class that had the 100th delegate. We're now on 431 delegates, so we're looking to replace that with a photograph of the 500th delegate when we get that. And it's very much a practical course as well. Each of the days you're going to be doing anything between 4 and 5 hands-on practical building teeth up. So hopefully it gives you the knowledge and the experience to then be able to go into practice and take on pretty much any clinical situation that's there. If you'd like any more information about Bioclear or the courses, etc., if you go onto the Dominic Hassel Training Institute website that's there, and it will have the list and the dates for the upcoming courses. I hope you found this hour helpful in opening you up to the world of Bioclear, and I hope that you'd like to find out more about it and then ultimately start using it in practice, because it's a really enjoyable way of being able to please your patients and create things in a really minimally invasive manner. Thank you for your time.